I'm really delighted to be here, and Audrey, thanks for the invitation and opportunity to come and talk to you this afternoon. I hope at minimally this is interesting, if not informative and helpful to you. Something I've been very interested in. I think you can't ignore it when you talk about addiction. You can't ignore this issue of stigma and discrimination and bias when you're talking about addiction. And I think there's good reasons why these things occur. They've been around for a long time, they're still with us, and we struggle with how to deal with stigma and discrimination. And as I'll tell you, there are some things that we think may be helpful. So, it's coming up for 50 years since the declaration of the war on drugs under the Nixon administration. There was, of course, a lot of kind of harsh rhetoric and punitive, being tough on crime stance associated with public enemy, declaring drug abuse public enemy number one. Interestingly, and I think importantly, now we talk about it as being public health problem number one. Now back then you could have argued that it's also public health problem number one, because it was public health problem number one then also. In fact, it is public health problem number one in most middle and high income countries all around the world. Substance use, substance-related conditions, alcohol in particular, but other drugs, illicit drugs, as I'll show you, are major contributors to premature mortality, disease, and disability. But the reason why I put this up is that there's been a conceptual shift. It's still number one, but public enemy is a very different approach in rhetoric and language than public health problem number one. Agreed? Public enemy versus a public health problem. So if you think about that term, that framework, that conceptualization is very different in the way that we might approach it. Public enemy implies you have to defeat it, usually through some kind of battle or war, as the war on drugs indicates. Public health problem would indicate some kind of public health model, including prevention, treatment, and recovery. And where we've come from actually is we've moved along. When we think about the laws that have been passed over the last 50 years, we've gone from the kind of more punitive laws, such as the Controlled Substances Act and the Anti-Drug Abuse Act of the 1980s, which was had disproportionate sentencing for crack cocaine, for example, 100 to 1 ratio between crack cocaine and powder cocaine in terms of prison sentences. And then more recently, we've had things like the Mental Health Parity and Addiction Equity Act to provide more equity in terms of funding for treatment and through insurance. The Affordable Care Act, of course, made substance use disorder a medical necessity. It moved it from this idea of, parity, you've got to treat it the same, but you don't have to treat it, so you can opt out. The Affordable Care Act said, okay, if you're an insurance company, then you have to treat mental health and substance use disorder. It's a medical necessity. You have to include that in your insurance plan. And then we've had more recent laws still, again, focusing on more of a public health approach to dealing with these problems. I was actually at this session. This was the first ever National Drug Policy Reform Summit. It was held at the White House in 2013, and I was asked to present some data from studies that I'd done on this issue of stigma and terminology and what that means for implicit bias, and I'll show you some of those studies. But the point here was, under the Obama administration, was that they wanted to mark a shift in explicit public policy away from the harsh rhetoric and punitive stance of the war on drugs towards a broader public health approach. It doesn't mean getting rid of the criminal justice system when it comes to drugs, but it meant that it was taking a different stance. It was saying, acknowledging that approach had not worked well and moving away toward a public health approach. Now, The reason why I mention these issues is that, and put this in context, is because when you think about these problems, the age-old question is, and this relates to the stigma and discrimination around these issues, is it a criminal justice issue or is it a medical issue? Right? Is it really that people are just doing bad things and they should be punished for, i.e. drug use, or is it they're sick and they can't help it and they should receive treatment? And so this is the battle. Even today, I was on NPR on Point a couple of weeks ago, and they were talking about a case in the Supreme Court, which is happening in Massachusetts Supreme Court, about a person who was on probation, a woman on probation, addicted to heroin. She was required to maintain abstinence, and she had relapsed. And because it was a violation of probation, the judge sentenced her to 2.5 years in prison. Okay? So the court case being in her defense was that how can you jail somebody for becoming symptomatic of a psychiatric illness, of a substance use disorder? Or can you do that? Right? So anyway, I was asked to give some opinion on that, and I've been approached, obviously being in Massachusetts, I'm approached a lot from different attorneys about this case. But it's the age-old issue. There are people on the show, on the On Point show, who are saying people who are addicted, they can control it. They can control their use, therefore they're just engaging in willful misconduct. It's not a disease of the brain. That's rubbish. We shouldn't be talking about it as a disease of the brain. The brain changes anyway as a result of lots of things. So these are people in the field of addiction who are arguing this. So even in the field of addiction, there's still a debate. There's not great, there is, I think, mostly consensus around the nature of these things, but still some people would argue that no, the people they're engaging in willful misconduct. So this issue of are they engaging in a compulsion that's beyond their control, or are they actually just engaging in indulging in something that just makes them feel good and therefore they should be punished? So this is an age-old debate, and this is played out in the war on drugs. And still today, in the criminal justice system, we know about 70 to 80% of prison inmates meet criteria for either a substance use disorder or another mental illness. So the large majority of our inmates in the prison system have a substance use disorder or a mental illness. So in terms of an outline of what I'm going to talk about, I've already mentioned a little bit, but I'll just give you a few more stats on just the burden of the diseases, burden of disease related to substance-related conditions, and how the research is really has revealed that addiction is highly stigmatized. I'll show you some of the data around that, and that people in general, their understanding of the biomedical nature of substance use disorder is increasing. But interestingly, it doesn't seem to be affecting stigma. And I think there's some interesting reasons why that might be. That, as I've alluded to, conceptualizations, how we frame, talk about, consider an issue relates, it reflects, but also affects our approaches to dealing with it. And that when we think about stigma, it's strongly influenced by two factors, I think, cause and controllability, and I'll go into what I mean by that. And then what to do about it. What can we do about stigma in terms of maybe looking at education, educating people about the nature of substance use disorder, what it does to the brain, the central nervous system, and how that impairs people's ability to regulate the impulse to use drugs, as well as personal witness. So this is the idea of putting a face and a voice on recovery. Has anybody heard of faces and voices of recovery? Yeah, so many people have. Faces and voices is exactly that. It's putting a face and a voice on recovery. Why is that important? Because it breaks stereotypes. You're actually surrounded by people who are in recovery, but they're in the closet. You never know they're in recovery. So what happens is the only time you actually hear of addiction is all the bad stuff. Lindsay Lohan coming out of rehab and relapsing once again, crashing her car, getting a DUI or whatever, right? That makes headline news. You never hear about all the people in recovery, sustaining recovery, that's not headline news. And because people tend to go into hiding when they get into recovery because of the stigma and shame, discrimination and fear of that, what might happen to them, and there's good reason actually to support that fear. I'll remind me if I don't remember to do it, but we're just finishing this big national recovery study where we're finding, just publishing this paper now, where people in recovery, years in recovery, still suffering from discrimination, both personal slights as well as violation of rights, because someone knows of their history of drug and alcohol use, okay? Even though they're in remission, in remission for a long time. Anyway, and the other thing is terminology and language and why that's important, so I'll talk about that. Now, I'm sure you're all very familiar with the current crisis, the opioid crisis, the opioid overdose crisis, more aptly called. That is a tragedy that is happening all around the country, has been happening, growing for the last 15 years, but it's in the context of more endemic problems. Even though it's comparatively more lethal, we have more people die from alcohol. 100,000 people die every single year, have done for many decades in this country. Around the world, 3.3 million people die from alcohol every year. That's 10 times the amount of all illicit drugs combined worldwide. It's the leading risk factor for death among men of working age, alcohol, worldwide. We have 23 million people who meet criteria each year for a substance use disorder in the US. We have another 40 to 60 million people who don't meet criteria for a substance use disorder, but they're engaged in hazardous or harmful use that affects health and well-being as well as safety. The economic cost is about $600 billion every single year. The price tag for substance-related problems and conditions. The largest portion of that, it includes criminal justice and healthcare, but actually the largest portion is lost productivity. So we were talking this morning about employment, how important that is. When you're sick with a substance use disorder or impaired through intoxication-related illness, you don't go to work or you don't work as well. So or if you're very addicted, you don't work at all. You don't have a job. Your job is just getting and using drugs. Becomes the abnormally high priority as a result of the brain waste hijacked in addiction. But $600 billion is the price tag. We're willing to write that check. We're not that smart. I was just speaking with someone earlier about how we failed to connect the dots. So it was Audrey, just how that price tag, we're willing to write the check for that, but if we were smart, if you were running a business and that was you'd be looking to say, well, what's causing that, and then how can we take some of that money that we're losing and invest it for the future so that we can actually start preventing some of this. We don't do that. We just willingly write the check to the criminal justice. Oh, more people, let's lock them up. Oh yeah, it's $60,000 a year to lock someone up in California. Well, we'll pay that price, no problem. Okay, but $60,000 for treatment, no way. Even though it's more effective than locking somebody up who has a substance use disorder. And substance use disorder is a large driver of the crime, the criminal activity, for which we are locking people up. We have about 14,000 treatment facilities around the country, about 100,000 mutual help groups like AA, NA, but only about 10% of people, including those who access mutual help groups, which is the most accessed resource for recovery, only about 10% get help in any given year. And a major barrier, it's not the only barrier, but a major barrier to seeking help is stigma and the fear of discrimination. So what do we know about addiction and stigma? So what is stigma? You can think of stigma as a attribute, behavior, or condition which is socially discrediting. Discrimination is really the unfair treatment of people who have that stigmatized condition. So you have the stigmatized condition, and then you're treated unfairly because of that. That's discrimination. So we have both stigma and discrimination going on. It turns out, well, think about, well, How stigmatized is addiction in the United States compared to being HIV positive, being a criminal? What about other countries? So they did this, they looked at this to find out across 14 different countries. The World Health Organization did a study where they looked at 18 of the most stigmatized conditions, and they took a sample of 1,000 people from each of these different countries. And they asked people to rank order the most stigmatized to the least stigmatized conditions of these 18 very stigmatized conditions. Number one, across every single country, illicit drug addiction was the most stigmatized condition of the list of 18. It beat out even being a criminal, having AIDS, being HIV positive. And number four was alcohol addiction. So two of the top four were addiction, illicit drug addiction being the most stigmatized. Now, substance use disorder, of course, is a psychiatric illness. It's in the DSM as a psychiatric illness. It is a mental illness. It's an illness that affects the brain. But when you compare it to other kinds of psychiatric illness, it tends to be much more stigmatized. This is a study where they compared that. They looked at people with mental illness and addiction, and then they asked them, the kinds of questions they ask in these surveys are, to assess stigma is, kind of social distance is one of them, is would you have someone with a mental illness marry into your family, marry your son or daughter or brother or sister? And would you have them as a co-worker? Would you have them as a neighbor? Okay, so these are the kinds of questions that are asked in these surveys. And we know from other surveys that anyone with a mental illness is more stigmatized. People are frightened of people with quote-unquote mental illness. They're even more afraid of people with addiction, with an addiction history. And these data just highlight that. Relative to people who have some kind of other kind of mental illness, they're more unwilling to have someone with an addiction history marry into their family, or someone with, or be a co-worker, or be a neighbor. Quite substantially different. And this relates to this issue of cause and controllability. Relative to other kinds of psychiatric illness, people view people with substance use disorder as more to blame for their condition, which makes sense, right? Because if you think about it, involves initially an element of choice, right? You have to choose to pick up the drug, the alcohol, the drug, imbibe it. And there's something that happens, of course, thereafter, which I'll go into. But this has been the case that what we find is that people are perceived to be more to blame for their condition. This one is so this one is to do with treatment. So overall, people with addiction are viewed as being more to blame. But if you portray it as having had treatment, then the stigma tends to go down a little bit. So that's what they did in this study. They compared people who weren't treated to people who were treated, and they found the people who were known to be treated with more favorable views, who are more likely to be willing to have them marry your daughter, or be a neighbor or a co-worker. It also has an impact on treatment seeking, even among people who are affected by the illness themselves. In this case, it was a study of alcohol use disorder patients. What they found, and I believe this was a pretty large study, 35,000. It was an epidemiological study. So they found that people with an alcohol use disorder who had more stigmatizing views of alcohol use disorder, so these are people who suffered from it, were less likely to seek treatment, even independent of their severity. So even if they were very severe, but they had this belief that there was a fear that they were going to be stigmatized, or people with this disorder were stigmatized, they would not seek treatment. So this kind of supports this notion, which is reported every year in the National Survey on Drug Use and Health, which is a nationally representative survey which addresses drug use and attitudes and behavior, that one of the major reasons why people don't seek treatment is because of the fear of stigma and discrimination. Also leads to more dropout from treatment, as well as poorer treatment from family. This was a study done in Australia where they found that they were treated unfairly because people knew of their drug use histories. People became afraid of them when they told them of their drug use history. They noticed that people were more afraid of them. 45% felt that some family gave up on them after finding out about their substance use, and there was a greater perceived discrimination that was associated with increased dropout from treatment. What about clinicians? Even clinicians are people too, right? So I'm a clinician myself, so. But we're not all bad. This was one looking at, this was done in the European Union, looking at about 1,000, just under 1,000 clinicians, looking at attitudes towards substance use disorder compared to other kinds of illness, including mental illness like depression, but also other illnesses. And what they found in this study was that it was the less specialized or less educated clinician workforce that had the more stigmatized attitudes towards. So the more exposed, the more familiar you were with people with addiction and substance-related conditions, the less stigma you had. So the highest stigma was on primary care, was from primary care physicians who actually had very little formal training in dealing with substance use disorder, understanding their nature. So there's an interesting idea there about education, and people are more educated and also more exposed, have more intimate exposure to individuals suffering from these conditions, had less stigma. And this was a study, actually it was a qualitative, systematic review of studies of healthcare professionals about their attitudes and behavior towards people with substance use disorder. Again, they tended to view people who are less specialized, tended to view people as being, people with substance use disorder as being violent, more manipulated, less motivated than other patients, and more avoidant regarding SUD care, which actually may result in shorter visits. So it may come out sideways, is their reluctance to treat them would result in shorter visits and also fewer visits, and less going out of their way to try and help somebody or meet somebody's for an appointment that's outside of their normal scope of practice because they have a substance use disorder and are viewed to be engaging in self-indulgence. So a brief recap, addiction is among the top, if not the top, most stigmatized condition across different societies, particularly in middle and high income countries. Compared to mental illness, other types of mental illness, people hold more stigmatizing views toward addiction. Perceived stigma is a major barrier to seeking help and seeking it earlier, and predicts earlier disengagement. And clinicians generally hold negative views towards addicted patients, particularly those with less specific addiction training. So what about conceptualizations and terminology in addiction? I've alluded to this, but this is the question: why is addiction so stigmatized compared to other social problems and health conditions and even other psychiatric illnesses? And I've kind of alluded to this already. What do you guys think? Why is it so stigmatized?
I think it's a choice.
Mm-hmm. Yes. So it's viewed as being their choice, their decision. They're making a decision to use it. Anything else?
Viewed as a personal weakness.
Personal weakness, yeah.
We consume a lot of negative images, both on television and movies, around addiction.
And why does it make it so stigmatized?
Because it looks dangerous.
Mm-hmm. Yeah. Yeah, I mean, you look even in the online media, or when they talk about opioid crisis, what do they show? Heroin needles, right? Pile of powder with a needle and a spoon, and right? I mean, so you get these, and sometimes they're in black and white for added dramatic effect. So yeah, but yeah, I mean, these are the kinds of images. Of course, the media is there not necessarily for public health. Of course, it's there to sell advertising. Don't forget that, right? They're just trying to draw clicks. That's what they're interested in, how many people click on the site. So the more controversial, the more emotionally evocative the images are, the more likely people are to spread the word, share it, get more clicks. More clicks means more money from advertisers. But these are the, I'm being cynical, right? I think it's true though. But yeah, so I think there's two factors involved in this issue, why it is so stigmatized. And it does have to, what you're all saying is cause and controllability, is we tend to have more compassion for problems, people with problems, if they can say, well, you know, it's not their fault and they can't help it, right? Didn't cause it and they really can't help it. It's just the way they are. I remember when I was a kid growing up, we'd always say that, you know, it's like, you know, if it's kind of a bit of an excuse actually. I remember, you know, it was like you always say, I can't help it. You know, I've got to do this. I'm out of order. I'm out of control, but I can't help it. You know, but if it's true that you really can't help it, then we tend to have more compassion for people. This was this court case I was telling you about. It's now in the Supreme Court, Massachusetts. Can people with addiction really help it or not? Right? Are they engaging in willful misconduct, or is there a medical malfunction that's gone on in the brain? Okay, so this is the debate still going on today. Okay, even though for hundreds of years addiction has been recognized as a disease of the brain, for at least a couple of hundred years, documented as that from medical people who have been studying addiction and working with addicted cases. So when we say yes, it's when it's not their fault, they can't help it, stigma tends to decrease. If we say it is their fault, they really can help it, they're just engaging because they just want to, then stigma tends to increase. So I think those two factors, which are highlighted here, the greater degree of perceived controllability, they really can control it, stigma increases, as well as it is their fault, and therefore the extent of stigma increases also. Now, what have we learned from the last 50 years of NIH research in both genetics and neuroscience? A number of things. One of the things is relatively new. We've known for a long time that the brain is affected, the central nervous system and the body overall is affected dramatically and radically in an increasing dose-response fashion, whereby the more of a drug you've used over a longer period of time, the greater the impact. But we haven't known until recently the neurocircuits that have been involved in addiction, and now we have clarified what those neurocircuits are. And addiction is, we can think of addiction as a disorder of the brain or a disease of the brain or an illness of the brain that affects these neurocircuits of reward, memory, motivation, impulse control, and judgment. So it affects these areas of memory and reward down here. These are hijacked by drugs. And it also affects the prefrontal areas of the brain involved in inhibitory control. That is to say, putting the brakes on when you want to stop, not engage in a behavior. You put the brakes on, you think about the consequences. No, I don't want to have that extra piece of cake. No, I don't want to have that extra. I don't want to go over the speed limit. No, I don't want to get caught without my seatbelt. So you think through the consequences and you alter your behavior, you put the brakes on. In addiction, what happens is that becomes impaired, radically impaired in some cases. Not just functionally impaired, but also structurally impaired. That the changes in the brain can, again, be quite dramatic and radical, again, in dose-response fashion, depending on how long and how intensively you've been using. On the right-hand side here, is somebody who is addicted to alcohol, a 43-year-old, and that's someone who is a moderate social drinker. But you can see, you don't have to look very long or very hard to see there's a difference there. It doesn't look good, right? In fact, in neuroscience, we call this not ideal, this particular hole in the brain. But the point is here is that arguably, you know, if you think about how the central nervous system is affected, and when you see people who, a loved one or a patient or somebody that you know, repeatedly engage in drug use, despite all the harmful consequences that, and remorse that they feel, and yet they still go back and do it. They become homeless, they lose their job, they become ostracized from their family, even their friends, and still, it's not enough to get them. What's wrong with that person? This is what we call addiction. This is how we view it. Structurally, functionally, the brain is actually changed and radically changed in some cases. In fact, we know that these are responsible for what we observe. We see an otherwise healthy human organism with a propensity for life for roughly 80 years self-destruct and poison itself to death roughly 30 years on average prior to what Mother Nature intended. So there's something gone wrong with that human organism whereby it poisons itself to death. Mother Nature did not intend for that organism to poison itself to death roughly 30 years on average prior to what she intended in terms of a lifespan. But there is something gone awry in that human organism which produces that outcome. And obviously that is not a happy outcome. I think a lot of people who are addicted would say, if that was the only outcome, I might even go for it. But it's the misery. It's the misery and mental torture that goes along with active addiction, so oftentimes, which people can't stand. It's not so much the fear of death. So what do we know about the cause factor? So that was the controllability factor I was talking about, those two factors. We know that the brain, the prefrontal cortex, is radically changed, radically impaired. The reward system, through its neuroadaptations to this abnormally high level of reinforcement, tries to adapt to the presence of these abnormally high levels of reinforcement, and that neuroadaptation causes what we call tolerance. In the absence of the drug, creates a craving, a drug hunger. There's a deprivation there that produces this amazing hunger for the drug to stabilize the reward pathway. But also in terms of cause, we know that roughly from dozens now of large-scale genetic families, we've all heard, I'm sure, that alcoholism runs in families. There's both a family history effect. Part of the family history effect, which involves environment and genes, is the genetic effect. Half the risk for addiction is conferred by our genes. So, as my friend Robert West says, maybe the question is not why do people become addicted, but how come we're all not addicted when 90% of the population is exposed to a potent psychoactive drug that causes addiction called alcohol. Alcohol is the domesticated drug, the legalized illicit drug. It's a psychoactive drug. It accounts for the majority of addiction cases in most middle and high income countries. How come only 15% of people who are exposed to alcohol become addicted and the other 85% don't become addicted? Well, part of that is modulated by our genes, just the same as we have preferences and predilections for different types of foods and things that we like and like to do, different propensities. Part of that is in our DNA, and it's mediated through different effects. For addiction, there are two major pathways through which genes confer risk. One is through the reward salience on exposure to the drug. The other one is through metabolism. So, for example, when people are exposed to alcohol, alcohol is a psychoactive drug. It produces euphoria, disinhibition, anxiety reduction, sedation, and sleep. Things that human beings like, right? People like feeling that sense of escape, relaxation, sedation, euphoria, anxiety reduction. People use it to de-stress, right? It has those properties, those pharmacological properties. On exposure, you take randomly a sample of 100 people and you expose them to it. What's going to happen? Some people will take that drink, that exposure to that drug, and they'll say, yeah, it's all right, it kind of seems okay, but nothing special. Some people will actually take that drink and they'll say, ooh, don't like the way that makes me feel. It's a stiff drink. It's like 2 or 3 shots, right? So I don't like the way this is making me feel out of control. I don't like to feel out of control. Other people will love that drink so much that they'll poison themselves to death roughly 30 years early than expected. Now they don't know it. This is the thing. They don't even know themselves why they like it so much, or even that they like it more than other people. They just know that, wow, this stuff is really good. I like this stuff. And what we like, we repeat. We tend to repeat what we like, and especially if it's socially sanctioned as being a good thing to do, which of course alcohol use is. So this is why we have so many cases of addiction for alcohol relative to other drugs, because it's socially sanctioned, it's socially endorsed, it's a part of our culture. The other thing is through metabolism. People who have this genetic predisposition tend to metabolize those same substances, produce euphoria much more quickly, so they need more to get the same effect as other people do at a lower dose. So there are two pathways, two major pathways, through which genes can affect the repetition of exposure. Like I said, some people are just naturally protected because they say, I don't like the way that makes me feel. Is that choice? It's just by virtue of their biology that they're saying, don't give me any more of that, or 1 is enough, or 2 is enough. So that's kind of how these genetic factors influence the susceptibility to addiction. Again, people do not know they're on that path. All they know is this seems really good to me. My friends are doing it. I'm going to do it too. That's how it confers the risk. Now here's another thing. I mentioned this is we talk about it these days, and I think this has been an attempt to destigmatize. So, and again, the relative emphasis, if we place the relative emphasis on public health as a medical condition, then perhaps it will become destigmatized because we are referring to it now, for example, as a chronically relapsing brain disease. Ever heard that? Chronically relapsing brain disease. Sounds pretty heavy duty though too, right? Chronically relapsing brain disease. Now some people would argue that's too heavy. Number one, disease, maybe we shouldn't use the word disease. Maybe we should use the word disorder or illness. I was just rereading, I just did a review for Addiction, the journal Addiction, on an old book published in 1960 called The Disease Concept of Alcoholism. Anyone ever heard of that? Written by Alvin Jelinek. You might have heard the Jelinek chart, so in clinical settings, but he wrote another book, very famous book called The Disease Concept of Alcoholism in 1960. But interestingly, the reason why I bring it up is because he talks about this issue of disease back then. Should we call it a disease? Or should we call it an illness or a disorder or a problem? And his point of view, which I'm coming to share, is that when we hear the word disease, it tends to evoke this idea of infectious disease, implicitly even, that it activates that schema of, well, disease, don't you kind of catch a disease, right? Like the flu or something, that's a disease, whereas, so his point was, it may activate that schema, may not be the best word to use, but there are synonyms. Illness and disorder are not meant as gradations. They're not meant to reflect gradations of severity, but rather just as synonyms for the same thing. So arguably, maybe disorder or illness might be a better term than disease because it doesn't evoke this kind of I'm not quite sure that it's really a disease. And people in the addiction field debate whether it is a disease or not. Okay, maybe because it does arouse this kind of idea of the notion of disease as being something other than a behavioral health disorder which affects the brain. So disorder or illness, I think, equally could be used. But having said that, I think my point on that is that if you call it a disease, then it should meet the criteria for a disease. In fact, it does meet the criteria for disease. So there's nothing wrong with calling it disease. The question becomes a question of utility. Not so much definition, but what is the relative utility of calling it a disease versus disorder or illness? So I think when you answer the question of utility, maybe it's better to use disorder or illness. Because it doesn't evoke any negativity and it still communicates the same idea. Now, why is it with addiction that we have to emphasize the idea of disease at all? Why don't we call depression major depressive disease, or bipolar disease, or schizophrenia, schizophrenic disease? We don't do that, right? I think the reason why is because we don't have to as much, just like that survey showed, right? Is that, oh, wait a minute, it's not really their fault that they got schizophrenia. right? That's more genetic. In fact, it's about the same as addiction in terms of the genetic risk. So, in other words, with schizophrenia, not imbibing something, although cannabis can induce schizophrenia and can catalyze schizophrenia for those with genetic predispositions. But why the relative emphasis? I think the relative emphasis, why we talk about addiction as a disease and addiction as a disease of the brain, is because there's a need to overcome the stigma, right, of addiction being one of indulgence or illness. Is it indulgence or is it illness? So I think that's why there's been the push from NIDA on describing it as a chronically relapsing disease of the brain. Now here's the, sorry for the long-winded explanation, but getting to this study here, this is from the General Social Survey, where they looked at the change from 2006 to from 96 to 2006 in major depression, schizophrenia, and alcohol addiction, and how attitudes have changed regarding, is it biomedical, is it bad character, are these things genetics, neurobiological, and this is the change. You can see this means good, positive change here on these bars. This is the opposite direction. Mental illness overall, and for all three of these conditions, depression, schizophrenia, and alcohol addiction, gone up, chemical imbalance gone up, genetics gone up, neurobiological all gone up. That's what we would hope with more education and learning, but only with the alcohol addiction, it was due to bad character. Also went up. It went up even though you got more people saying, yeah, it's neurobiological, it's a chemical imbalance with alcohol. So people are learning about it as an illness, as something that happens in the body, but also viewing it as bad character. Even though, and so there's just been this issue of emphasizing it as a chronically relapsing brain disease. Now, the thing is, with describing it as a chronically relapsing brain disease, there's a problem with that. What do you think the problem is? If you have a chronically relapsing brain disease, does your future look good? Yeah. Will you ever get better? Maybe not. Right? So here's the other side of the coin here is that, yeah, maybe it's, the intention is to reduce stigma. Maybe it does, maybe it doesn't. But I think a lot of people, it can increase stigma because people think, oh my God, this person's got a chronically relapsing brain disease. They're never going to get well. They're always going to be susceptible to relapse. I don't want them marrying into my family. I don't want them as a co-worker. I don't want them to be my neighbor. We know most people with a substance use disorder, with addiction, actually get into remission. It can take them quite a while to do so, but the rates of remission are very high. Upwards of 2/3 of people actually get into full sustained remission who have a substance use disorder, alcohol addiction or other kind of drug addiction. So that's very high rates of sustained remission. It's in fact what we call a good prognosis disorder. It's one of the best prognosis disorders of all psychiatric illnesses in terms of its recurrence. You get into remission, you can stay there for the rest of your life. It can take many years to achieve remission. I think this is where the chronically relapsing nature of it comes in. I don't have this graphic today, but a graphic I like to show just shows the timeline, the clinical course of addiction. And yes, it's a bumpy ride into full remission. It can take many years, multiple treatments on average. Some people get into recovery right away. Some people, on average, takes many attempts before they get into recovery. But the majority of people actually achieve full remission. So why it matters how we conceptualize it, what we call it, and people with it. I've done a lot of work in this area of language and implicit bias and cognition, implicit cognition, because I think our language both reflects but also affects or influences our approaches. Again, this whole idea, is it a crime, is it indulgence, or is it a disorder? Okay, and there is actually a language, a terminology, and a rhetoric that goes along with that. I mentioned this already, the war on drugs, particularly after the Anti-Drug Abuse Act of Bush Sr., 1986. It's updated in 88. But what did that do? That introduced this very harsh penalty for crack cocaine. Remember Bush Senior was like super tough. If you do the crime, you do the time. It was a time of we're sick of crime, violent crime also, but it was a very tough stance on crime. We're going to lock you up, you're going to do time. Okay, that's what happened. Prison building exploded. If you'd invested in prisons back in the 80s, you would have made a fortune. That became a top industry in the United States. 5% of the world's population, 25% of the world's prisoners. That's what that produced. And it's not cheap, as I mentioned. This was actually $2010, roughly on average $31,000 per year to lock someone up. Anywhere from $14,000 to $60,000 of taxpayers' dollars to keep someone in prison for a year. Is that a good use of taxpayers' dollars? Are you going to actually help change that person when they come out? Are they going to be is this going to be for the better? Audrey mentioned this issue of the burning building analogy, which I use, and one of the other, the last point I make in that analogy is rebuilding permits. If you put the fire out and the house is a shell and they want to rebuild, and you say, no, I'm not going to give you a building permit to rebuild, right? Because you've got a criminal record, so you can't open a bank account, you can't get a job, you can't get a student loan. How do you get a foothold in recovery if you don't have a building permit to even get started? So this is one of the problems with treating addiction via the criminal justice system, which is what we've done, is because then not only do they have, doing that time, it costs taxpayers money, it's very ineffective when addiction is the driver of much of that crime. And then they come out and they've got a criminal record, and they can't get any of the things that they need, the recovery capital that they need to get a foothold in recovery, to even believe in some kind of future for themselves. So what can we do about this? So I think there are three things that we can do about stigma and discrimination when it comes to substance use disorder. I think, as has been shown, education. So the more educated people are and exposed to people who've had a problem with a substance use disorder, the more sensitivity, empathy, and understanding and compassion that they have, less stigmatizing attitudes they have. So education, personal witness, again, putting a face and a voice in recovery. This has started to happen, not just in the United States, but all around the world now, in different countries. People coming out of the closet saying, I'm a person in long-term recovery. And Michael Botticelli was perhaps the most famous example, who became the drug czar under the Obama administration. He always would say, he's a person in long-term recovery. And Marty Walsh, who's the mayor of Boston, another person in recovery, always says it when he speaks, I'm a person in recovery. And anyway, so there's more and more people kind of coming out of the closet, as it were, putting a face and a voice in recovery. So what that tends to do is it destroys stereotypes of what addiction is, gives courage to other people to come out and talk about it as well. Because believe it or not, you're actually surrounded by people in recovery, it's just that they don't talk about it because of the fear and stigma. So going the opposite track, a kind of a paradoxical way to deal with it is to come out first and then have those people then say, oh, this isn't what I thought an addict was like. This person's got a real job. They seem to be smart, they're articulate, they're going about their day, they seem just like me. So again, it breaks down these stereotypes. And then another way is changing our language. So here's a question I often ask. So people with eating-related conditions are always referred to as having an eating disorder, never as food abusers. So why are people with substance-related conditions referred to as substance abusers or drug abusers or alcohol abusers and not as having a substance use disorder? Do you ever hear anybody being referred to as a food abuser if they have an eating disorder? No. It just rolls off the tongue. I don't even think about it. Oh yeah, I work in the eating disorders field. Oh, you have an eating disorder. Oh, you're in recovery from an eating disorder. You're not I'm an ex-food abuser. Right? Or I'm in the food abuse field. I work in the eating disorders field. So again, why is that? It's cultural, right? It's cultural, and our language is habit. We don't have to think, maybe I should think more about what I'm saying, but normally we don't have to think about what we say. We can speak very, very quickly and articulate our ideas very quickly because our language is habitual. So you actually have to stop yourself from saying something you're normally used to saying right? Like if you're used to saying drug abuser, you have to say, oh, I shouldn't say drug abuser, I should say someone with a person with a substance use disorder. But part of it is cultural, and where did that cultural habit come from? It came from the idea, I believe, of this idea of engaging in willful misconduct. So if you call someone a substance abuser, what does that imply compared to someone calling someone as having a substance use disorder? So as I mentioned, I was asked to come to the White House to present some findings, which I'm going to present to you. I showed you this, is controllability and cause. And I did a couple of studies, which has now gone viral. Had no idea it was going to do that, but it was just something of interest to me, is would it really make a difference in people's attitudes if you expose them in the same scenario to describing someone as a substance abuser versus having a substance use disorder? The idea being, if you call someone a substance abuser, then it may connote or convey the idea that that person is engaging in willful misconduct because they're abusing, like a child abuser. It has that same connotation, that they're engaging in willful misconduct and they should be punished. Compared to, think about describing exactly the same person as having a substance use disorder, not as a substance abuser. It implies or may imply or connote or convey some kind of medical malfunction, especially with the idea of disorder. And, I think there's a lot of, in some ways, I think this has been taken too far, but the question, for PCness, political correctness, is it just I'm being politically correct and I just want to be nice and we should use correct language because it's nice to do so, or does it actually make a difference? So that was the kind of the question that I asked. And we published the results in a couple of studies. There were two scenarios, exactly the same scenario. In fact, it's almost identical to this woman I just described, who's in this Supreme Court case right now. It was almost exactly like that. This guy was on probation. This hypothetical guy was on probation, Mr. Williams. He was required to maintain abstinence. He'd relapsed, and he was up before the judge to determine his sentence, okay? In one of the scenarios, he was described as a substance abuser. In the other one, he was described as having a substance use disorder. Otherwise, they were identical. They were randomly assigned these vignettes to almost 600 clinicians. These were doctoral level clinicians, mental health physicians or psychiatrists, psychologists with PhDs and MDs. So I asked them to read the vignette, and then they had to answer questions. Do you think Mr. Williams should be punished? Do you think he should be treated? Do you think he's to blame for his condition? Do you think he can control his substance use, etc.? And they answered these questions. Depending on which one they were exposed to, they answered those things. And what we found was that, in fact, this was a follow-up study, but it highlights these same things. What we found was that clinicians at random, when they were exposed to the exact same vignette, but when Mr. Williams was described as a substance abuser, they were more likely to view him as in need of punishment, less in need of treatment, more to blame for his condition than the same person described as having a substance use disorder. This was a follow-up study we did in the general population, and the differences you see here are amplified in magnitude. So much more likely when he's described as, someone's described as being a drug abuser, substance abuser, to be less in need of treatment, more in need of punishment, more of a social threat, more to blame for their condition, less likely to be exonerated, and more likely to be able to self-regulate and therefore be engaging in willful misconduct. So here's the interesting thing for me, is that even among well-trained clinicians who are addressing addiction, they're still susceptible to this implicit bias when they're exposed to that term. So sometimes, even when we don't intend it, even when we don't mean anything by it, we construe implicitly more of a punitive bias towards individuals when we use the term abuse or abuser than we do when we hear the term disorder. So I think we should learn maybe from our cousins in the eating disorders field who never describe their patients or individuals as food abusers. Never ever heard that. Again, it's a matter of habit and cultural shift. People will say, oh, substance use disorder, that's kind of a bit of a long-winded. Person with a substance use, that's even more long-winded to say that. And there is a bias towards more efficiency in our language, towards capturing the same information in shorter terms, but not at the loss of stigma and communication. Again, eating disorder rolls off the tongue because it's a habit, it's culturally appropriate, and just shifting our language regarding substance use may make a difference overall in terms of our stigma, I would argue. This is the thing we kind of another article, this is an editorial, but it's that we haven't done a study on this, but the idea is the same, is this notion of clean and dirty urines. Ever heard that? I work in a clinical setting. I work at Massachusetts General Hospital. It's considered to be one of the top hospitals in the country because we're so compassionate and empathic, and we care for our patients better than anybody else. But I hear clinicians using this kind of language with patients among staff. The urine came back dirty. The urine came back dirty. So what does that imply about somebody? We don't use that kind of language in any other area of psychiatry or medicine. That's street language. Why are we adopting that in a medical setting? Is that going to be good for our patients to be talking about clean and dirty, perpetuating that notion of being dirty or being clean? So the idea here was to advocate for stopping talking dirty and removing that from our lexicon. I actually went to Budapest and presented to the International Society of Addiction Journal editors, and we created a consensus statement which was published. And now across the world of addiction science, you can't use these terms in scientific articles that are coming into addiction science because it induces this more punitive, stigmatizing bias. So these are some of the things that that we're suggesting that people use instead of older language, like calling someone a drug abuser or an alcohol abuser or substance abuser. Call them, the idea from the mental health field too is that it's a person-first language. So they're a person who suffers from that condition or has that condition. They are not that condition itself. I think it's more important with substance-related conditions. So they're a person or an individual or a patient with or suffering from a substance use disorder. Again, alcoholic, a person with who has an alcohol use disorder or an alcohol addiction. Dirty urine, the urine was positive for whatever substance. And heroin addict, another, one of my colleagues down at University of Pennsylvania has just done a study similar to this, just published this month, again, looking at the implicit bias induced by certain terms. He found the word addict also was a negative term that induced implicit bias against people with addiction problems. So in terms of implications for practice, I think more education, helping clinicians understand the nature of this. What we're trying to do with all the medical schools in Boston, which there are a lot, is we've got agreement now from all these medical schools to start to train physicians during medical school, require more addiction training as part of their curriculum. Okay, so historically they haven't done that, even though it's the top public health problem and has been for decades. Can you imagine that? It's just not incorporated into medical curricula. They get a little bit, but nowhere near as much as you would think, given how much of medical care substance use, alcohol and drug conditions actually consume. So again, avoiding certain terms, abuse, abuser, addict, dirty, clean, that kind of language, and clear communication of the nature of substance use disorder. I think if we want addiction destigmatized, we need a language that's unified and also that reflects the true nature of these conditions. And this is one of the things that we've been pushing for federally, is to actually change the names of our National Institutes of Health. So if you think about what do we have as NIDA, what does NIDA stand for? National Institute of Drug Abuse. NIAAA, National Institute of Alcohol Abuse and Alcoholism. I mean, alcoholism, that word in itself is outdated too, right? But it takes an act of Congress, apparently, to change the names of the National Institutes of Health. how are we going to get that done, right? But I think, you know, I've approached people, George Koob, who's the head of NOAAA, and Nora Volkov, talked to them about this, and other people. They do agree that it does need to be changed, and we do need to change this terminology. But I think the sooner we do that, the better, because we can get them out of these national institutions, extricate this kind of stigmatizing language, which you know now to be stigmatizing. I think that will send a message nationally, globally, that this language is unacceptable. And again, it's shifting, the language shifting our conceptual framework. Is it public enemy, or is it a public health problem? So I think our language should reflect that, and we still have the vestige of the rhetoric of the war on drugs that's still imbued in many of our institutions. So that's all I want to say. I've said too much. No, but thank you for having me, and we've got time for questions.